Now, next up, one of my absolutely brilliant colleagues, Professor Eleanor Scott, and you can read a lot about what she does, Professor of Diabetes. But one thing I will say to everybody, along with Helen Murphy, if there was no Eleanor Scott, we wouldn't be having CGM in pregnancy and type 1 diabetes in this country. They have convinced us the importance of the work they have done. So a huge thank you from all of us for the work that she has done, continues to do. So, she shapes services nationally, and huge amount of kudos to her and her team for doing what it is. So without further ado, let's hear from Eleanor.
Hi, thanks very much for that introduction. It's a pleasure to be here today to follow on from Ros and talk to you a little bit about technology and type 1 diabetes in pregnancy. So pregnancy and type 1 diabetes, what's the story? Well, basically, when a woman with type 1 diabetes gets pregnant, the glucose that's in her bloodstream crosses the placenta and gives nutrients to the baby, the developing baby. And basically, baby likes mum's glucose to be as close as normal to possible. And in pregnancy, that's between 3.5 and 7.8. We know that any extra glucose in mum's blood above 7.8 will cross the placenta and it will give baby more glucose than it needs. And in the first 12 weeks of pregnancy, this can interfere with the way baby develops, so particularly the way its heart forms and its spinal cord. And thereafter, once past 12 weeks of pregnancy, any extra glucose affects the way that baby grows, and the baby uses any extra glucose to grow big and basically put on weight. Now, the problem with having a big baby is that it means that you're more likely to need a caesarean section, that baby's delivered a little bit early, and that baby may well need to go to the neonatal intensive care unit for a small stay. Whereas a normal sized baby is more likely to be born closer to term, which is 40 weeks, by a vaginal delivery and stay with mum. It's worth saying, however, that diabetes can affect the placenta anyway, and it may not work as well at the end of pregnancy. So even women who look like they've got a normal sized baby growing may be advised to deliver a little bit early to make sure that baby's well. So, some positive news really first off. Did you know that 99% of pregnancies in women with type 1 diabetes will result in a live baby? Across the UK, we collect data every year on the outcomes of diabetes, type 1 diabetes and type 2 diabetes pregnancies as part of the Diabetes UK and NHS Digital National Pregnancy and Diabetes Audit. So we've got data now on over 18,000 pregnancies. So despite this good outcome, we do know that 1 in 2 women will give birth to a big baby. And 1 in 2 women, because of that, will end up giving birth by caesarean section. And related to that, most babies will be born a little bit early, before 37 weeks, which means that most of the babies will need to go to neonatal intensive care for a bit. So we know that's related to the higher glucose and baby getting that little bit extra all the time. But also we know that it's because most women haven't got their diabetes pregnancy ready before they actually get pregnant. And in fact, from the national audit, we can see that only 1 in 8 women manage to get pregnancy ready before they do get pregnant. So this brings me on to, have you ever wondered about that throwaway question at the end of your consultation when your doctor keeps asking whether you're planning on having children? And you sort of think, yes, possibly in the future, but I'm not going to say now. Well, the reason that we ask it is we know that working with your diabetes team to get pregnancy ready reduces these risks of having a big baby and the complications associated with it. And so if your doctor knows, or even thinks you might be in the future, then they can really give you extra support from the whole diabetes team to make sure that you are pregnancy ready. We know that using contraception regularly until you're pregnancy ready also helps, because it avoids you getting pregnant without getting your glucose where you want it to be for pregnancy. So what is that? Well, we'd be aiming, if we can, to get your HbA1c to be less than 48 millimole per mole. But to be honest, any reduction, if it's higher than that, is better than none. The target glucose that we'd be trying for if you're already using, say, continuous glucose monitoring would be a glucose between 3.9 and 10 for 70% of the time. I have to say that I find that quite a lot of women try to use the pregnancy targets, which are 3.5 to 7.8, to actually get that really tight control. The other thing that we do is check that all medication is safe for pregnancy. So that includes blood pressure medication, cholesterol medication, and also make sure that you're on the right supplements and vitamins such as folic acid before pregnancy. We know that technology can really help in pregnancy to stop having a big baby. So there's a study called the Concept Study that was led from the UK and Canada, and it was published in 2017. And basically this study gave women with type 1 diabetes either a continuous glucose monitor to use all through pregnancy, or they carried on through pregnancy using their usual finger prick monitoring. And what this study showed was that those women that continued to use finger prick were less able to keep their glucose in the pregnancy target range, and it meant that they had more big babies and their babies needed to go to intensive care. Whereas those mums that got the continuous glucose monitoring, they were able to maintain their glucose in the normal pregnancy range, and they had fewer big babies and their babies didn't need to go to intensive care. And the study showed that every 5% increase in time spent in pregnancy range improved babies' outcomes. So this was a landmark study that subsequently informed the NHS long-term plan. And basically, NHS England committed that by 2020-2021, all pregnant women with type 1 diabetes would be offered continuous glucose monitoring to improve babies' outcomes. On top of that, the NICE guidance that healthcare professionals adhere to has also been changed to make it clear that because of these benefits shown in the Concept Study, that women with type 1 diabetes should be using CGM in pregnancy. And NHS England implemented this in 2021 by putting the funding behind it to make sure that all women with type 1 diabetes can access this technology in England. So when using continuous glucose monitoring, it's a different way of thinking about glucose anyway, but even more so in the context of pregnancy. So we've already said that the glucose range is pretty tight, 3.5 to 7.8. And that we're aiming for time spent in that range during pregnancy of about 70% of the time. We know that each 5% increase in time in range improves outcomes. But in order to move towards this, then you need to be looking at your continuous glucose monitoring glucose data regularly. And this is something that Ros has already mentioned. So there are those day-by-day adjustments that you need to make where you're using your data, you're looking at it to correct if you're above target pre-meal or after a meal, to warn you about whether you're going hypo so that you can take action. But also it's about reviewing the data every few days as well and looking at the patterns that are going on so that you can make sort of slower changes really to mealtime ratios of your insulin or whether you need an increase in your background insulin. And the reason this is important, particularly in pregnancy, is that your glucose changes all the way through pregnancy. So every single week, your glucose does something different. So that can make it tricky. And that's really where continuous glucose monitoring helps. So what does time in range look like then in the context of pregnancy? Well, if you look at my top picture here, I've marked on it the pregnancy target ranges. So there's the 3.5 to 7.8 just on the side. So the red one's 3.5, the yellow line's 7.8. And you can see with the yellow bars that that's where this pregnant lady is spending most of her time outside of the glucose target range. So she's still spending 47% of time in the pregnancy range, but 52% above. And that means she's more likely to go on and have a big baby. Whereas the trace below shows what a glucose looks like across the 24-hour day if you're managing to get more time in range. So this particular lady has got 82% time in range, and you can see how little she dips out of that, and as a result is more likely to have a normal-sized baby. So using continuous glucose monitoring early in pregnancy, we know it's stressful worrying about glucose and the effect on baby. And we know that glucose values are hugely variable at this stage in pregnancy, which actually is normal. There's an increased tendency to hypos without the usual warning signs and a drop in insulin requirements. And using continuous glucose monitoring just really helps to manage this. You can see on the picture below that this lady's having hypos and then highs as a result. And the continuous glucose monitoring can give you warning of the hypos, so you can actually stop them happening, can stop the high peaks afterwards, and therefore spend more time in the pregnancy range. But using it during the rest of pregnancy also helps because, as I've said, pregnancy changes quite a lot in the way it affects glucose. And we see that women have to increase their insulin doses, particularly from about 20 weeks of pregnancy onwards. If you look at the trace below, you can see that across the 24-hour day, it's mainly mealtime glucose that's a bit high. And we find that by the end of pregnancy, mealtime doses are likely to have doubled, tripled, or even quadrupled, which can be quite scary to a lot of women. And also the background insulin may well also have increased by 50%. During labour, using the CGM means you can stay on the tech, and also your partner can help support you as well because they can download it on their phone so they can help. As soon as the baby's born and the placenta's delivered, mum's insulin doses return to pre-pregnancy amounts. They drop massively, which also can come as a shock. But again, using CGM can help manage that. And also anecdotally, as Roz has touched on, using CGM can really help keep things on an even keel while adjusting to having baby and breastfeeding. We know it's not necessarily easy to do this, and so we've developed with the Diabetes Technology Network a variety of resources to try and help women to use this fantastic technology during pregnancy. So one of these things, and it's free for anybody to access, I've put the link below, but it's the top tips for using continuous glucose monitoring in pregnancy. We cover everything from setting up the CGM, setting the alarms and the targets, but also the things you need to do across the day with your meal times, with your insulin, that will help you get that time in range. On top of that, we've got some support videos and user stories that are just 5 to 10 minutes long, again, about people's experiences of using CGM in pregnancy. So we've got some lovely ladies who've all been through pregnancy, giving you their stories that are worth listening to. And also we've got some healthcare professionals that talk about using CGM at each stage of pregnancy. So you can dip in and out of those. And again, the link's just below. Basically, continuous glucose monitoring is transforming the experience of women with diabetes in pregnancy. I have to say that having CGM available during the COVID pandemic has been invaluable, and I can't imagine how we would have done without it and without people being able to share their data over the cloud with healthcare professionals. What it has done is reduce the burden of hospital visits in pregnancy, making it feel far more like a normal pregnancy, which of course we want it to. We want you to enjoy being pregnant. Traditionally, women would come every week and sit in the antenatal clinic all afternoon or all morning waiting for their appointment. And we've managed to avoid that now by doing a phone call or video call and looking at the data in between. Plus, by using CGM, women are able to achieve glucose levels that are far more like a normal pregnancy. So that again adds to this experience and makes it more enjoyable. What of the future? Well, I think we'll almost certainly continue with virtual visits as well as some face-to-face appointments with the team during pregnancy. We're also really interested in how continuous glucose monitoring links with pumps through the artificial pancreas, closed loop, and we're currently running the first major trial of it in pregnancy here in the UK at the moment. So I hope that in the next couple of years we'll be able to report on the benefits that that has as well, so watch this space. So finally, just some take-home messages from me. Please do discuss your hopes for pregnancy with your diabetes team before you actually stop contraception, because they want to help you get pregnancy ready, as it's really important for a healthy baby. And I think it's worth saying, that using technology and adopting that and getting on board with it really can help pregnant women to achieve the glucose goals and allow their baby to develop and grow healthily. So I think it's all looking really positive, and hopefully in the next couple of years with the closed loop study coming through, we'll be able to give you some more good news as well. So I'll end it there. Thanks very much for inviting me to speak.
Thank you, Eleanor, as ever. Eloquent, fantastic, gives a very fantastic overview as to what's going on from the clinical side, what we're trying to do. So, as part of the NHS England long-term plan, we had made a commitment to make sure that everywhere, women who were pregnant with type 1 diabetes would get access to a continuous glucose monitor. And that's the situation at the present moment of time. And if it's not happening anywhere, then please do let me know. It's certainly policy, got teams dedicated towards it. There should be absolutely no gap in the system. As regards some questions about the other countries, I'm aware that Wales do have the policy. We are working with the other nations. And as I've said to all the other nations, for me, all the policies we do, we learn from other nations. Our policies are also open for them to look into and adapt as may be needed.